So, what's the deal with women and bipolar disorder? In this Women's History Month, I want to take just a few minutes to talk with you about how bipolar disorder can present differently, how it can get missed in women, and what we can do about it. So let's think about this together. I'm going to tell you the story of a young person I treated a number of years ago, young woman who had a history of recurrent depressive episodes with patterns of self-harm and suicidal thinking. And then when they were in their early 20s, they had an acute manic episode. And by manic episode, that means the opposite of depression. Not just a mood change, but very high energy, hardly sleeping, not needing any sleep, grandiose ideas, even psychosis and delusions, paranoia. It was a big mess. They were hospitalized, meds were changed and adjusted, and they were discharged to a treatment program, like a short-term residential program. In that program, the psychiatrist there refused to believe that my patient had had a manic episode. They insisted that it was just borderline personality because of the history of self-harm, despite the hospital records, despite my input as her psychiatrist, and despite her therapist's input, also another woman, and he absolutely could not believe it. Now, luckily, it didn't change anything. We kept the meds as is, but they tracked my patient in a borderline treatment program, as opposed to for mood disorders and psychosis, which was not helpful, not what they needed. So let's think about how does it present differently. Well, first of all, the rates of bipolar are about the same in men and women, but women show many more depressive episodes than men and are more likely to present with depression as their first episode, which is really what happened with my patient. So they are going to look more depressed tonally. Doesn't mean they don't have mania, but depression is more their tone. They have often they have bipolar type 2, which is a lot more of the depressive center of the illness, with not quite full mania, but hypomania. That is more common in women than in men. Their comorbidities, so women are more likely to present with comorbid or coexisting anxiety disorders, eating disorders, PTSD, compared to men who are more likely to present with substance use disorders. But again, all of that anxiety, PTSD, eating issues can get tracked differently because of the perception of women, and so the bipolar symptoms may get missed or dismissed. Physical conditions are more common in women, such as thyroid disorders, autoimmune disorders, migraine, all of which, again, can lead to women patients being dismissed, disrespected, or their bipolar symptoms being minimized or not seen for what they are. So there's a lot of layers at which women with bipolar disorder can be missed and dismissed and then treated incorrectly. So the other critical thing, of course, with women in bipolar disorder are the reproductive cycle. Their entire life. This is from the time you start your menstrual period and have premenstrual periods. Before premenstrual times are high risk time for mood episodes anywhere across the bipolar spectrum. During pregnancy and postpartum, higher risk of mood episodes, both depressed, manic, and all through women's lives, that of their reproductive cycle, and then even into menopause, that's going to impact the likelihood and risk of mood episodes and mood symptoms. So, given all of this story, which is, just all in all, not also that surprising given how women are treated in our health system, what can you do? Well, if you are concerned about yourself or someone you love, you want to be able to speak clearly about the concerns and don't take no for an answer. Not that you're shopping for a diagnosis, but if you know there's something wrong with yourself or with someone that you love or that you care for, you want to find someone who's going to listen. tracking mood, energy, and sleep are some of the most valuable things you can do in making the diagnosis of bipolar and then in managing it. Those mood can be, in mania, it can be euphoric, it can be irritable, it can be angry. Energy is definitely a shift up in mania, down in depression. Sleep, you need a lot less of it. It's not insomnia where you stay up late, can't go to sleep, but you sleep all day. A manic period looks like needing a lot less sleep. And of course, psychosis can happen in either depression or mania, but it's very common in full-blown manic episodes. So keep notes, keep speaking up, get advocates to come with you, take notes at all of your meetings, and don't just keep talking. If you want more information, and there's a specific chapter in our most recent edition of Bipolar Disorder for Dummies, you can take a look at that, wherever it is you might find such type of materials on pages between covers. Okay.